Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins neurosurgeon Eric Jackson will be speaking about understanding and treating craniosynostosis. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by Dr. Jackson. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question in the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note, if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now, I would like to welcome Dr. Jackson to begin our presentation.
Hello, I'm Eric Jackson. I'm one of the pediatric neurosurgeons at Johns Hopkins who takes part in our multidisciplinary craniofacial clinic. And the idea of this talk is primarily to give a quick summary for parents and maybe some practitioners about the basics of synostosis and things we do. It won't be very long, but just to kind of hit the major points and then things to lead us into questions. A few disclosures. I just have to say I'm a consultant for Integra Life Sciences, which is completely unrelated to synostosis. And then for the most part, during this talk, in general, if not otherwise specified, I'll be talking about single suture synostosis, not necessarily syndromic multi-suture. So to start with the basics, what is craniosynostosis? And effectively, it's a condition related to the premature fusion of the sutures of the skull. So we'll come back to this diagram, but the skull has all of these suture lines built in that allow the head to grow. And if one of those closes early, it can cause assorted problems. The main things we think about are you can get a skull deformity based on growth not occurring at that suture line. There is some association and concern regarding development. And then there can also be concerns related to elevated intracranial pressure, which may or may not tie into some of those developmental concerns. In terms of why do we treat, obviously there is the correction of the skull shape. There is discussion of preventing abnormal brain development, and we'll get a little bit more into the literature on that and how it's a little bit controversial, or should I say, rather than controversial, just not clear, and then potentially treatment or prevention of elevated intracranial pressure, which may play into that development. Thinking about cosmetic deformity, one important detail of that is that we often will see it worsen over the first 6 to 9 months. And there's two main reasons for that. One is that that's when the skull is growing the most. And so obviously, if it can't grow in one direction, the time of growth is going to make that more and more noticeable. So it's oftentimes kids will be born with an obvious appearance of synostosis. But sometimes it's kind of questionable whether it was positioning in utero versus the bones being fused. And it's important to know if it is synostosis, the skull appearance and deformity will likely worsen over time in the first 6 months rather than improve. Another thing that just makes the cosmetic deformity more noticeable is that the head is its largest proportion of the body as a baby. As we get bigger, the rest of the body grows more than the head does, so the head becomes a little bit less noticeable. And if we use here a normal growth curve going from 0 to 18, this kind of hits on a couple of those reasons why. So if we kind of look here at 12 months, and we're just looking at average, you can see here, average head at 12 months is between 46 and 47. And at birth, it's 34. So you're growing on average about 12 to 13 centimeters in the first year of life. If we look at 18 years of age, it's a little bit below 56. So the head is growing more in the first year of life than it is pretty much the rest of life, or about the same. And so it's one of those things that's one of the reasons why the first year is so crucial in terms of synostosis and its treatments. In terms of developmental concerns, there are a number of studies that show cognitive impairment comparing patients with single suture synostosis and others without. There are more studies with metopic and also a number with unicoronal as well. And there are obviously with syndromic synostosis, there are separate studies with that. But the literature obviously comparing developmental concerns versus shape, the developmental concerns are definitely less well understood. And there's actually some conflicting literature. One thing is the synostosis the cause of the developmental concerns? Or is there a common underlying cause? So is it that the brain growth is restricted, and that's what causes developmental delays, maybe because of elevated intracranial pressure? Or is it the fact that there's a gene that just isn't doing something the way it should, and that causes both the synostosis and developmental delays? In that case, treating the synostosis isn't going to have impact on the developmental delays at all. Um, as such, it that plays into not knowing whether the timing or the type of surgery can affect the delays. Obviously, if it is the synostosis itself that's contributing, then the sooner you treat that, then the more likely it is that you're going to get benefits from that. So that would say that an early intervention may have more of a benefit than a late intervention. But we don't necessarily have good literature to document that. And, to truly show that, you would probably need twins with synostosis, and you treated one early and one late and see a difference. And obviously that's a study that's never really going to happen. So we're kind of reliant more on just comparing across groups. Now going back to the normal skull, I think this is the best way for us to look and think about how synostosis develops. And so a couple of things to point out. So we have the metopic suture in front, two coronal sutures, and then the sagittal suture, and those make out the anterior fontanelle. The posterior fontanelle, which is much earlier to close, is really at the junction of the lambdoid sutures and the sagittal suture. And then the way we tend to think about it is if one suture closes, so for instance, the sagittal here, then the head can't grow in the direction away from that. So sagittal synostosis, it can't grow out here, so you get a long, narrow head. One other thing we see is that the anterior fontanelle will often get sent patients based on what's felt to be an early closing fontanelle or a small fontanelle. And that in and of itself can be normal. An anterior fontanelle can close normally as early as 3 months. One thing we do use in my physical exam, and we'll talk about it a little bit, is oftentimes if one of the sutures is fused, the fontanelle is normally a diamond. Effectively, you can think about four triangles pointing in different directions. And for instance, if the sagittal suture is fused, often the triangle and the half of the sagittal suture will be closed. So it's not a diamond, it's a triangle pointing forward. So those are kind of clinical exam things that we can use. So in terms of the workup for synostosis, we typically can make the diagnosis by appearance, and especially sagittal synostosis, that's one that we typically recommend treating without any kind of imaging in many cases. But things that we will look for, so the fontanelle, is it open? Is it flat? What's the shape of it, like I talked about? Ridging, oftentimes a fused suture will be ridged. Now, you can also have ridging in a normal head because from being in utero, the bones can overlap. And that's something that on exam we can try to differentiate what's ridging related to synostosis versus overlapping bones. And the other features that we can use to kind of help with that are head shape. Like I said, with sagittal synostosis, you may have a long, narrow head. With coronal synostosis, it'll work its way into the face. And also we'll use the ear position as well, as that will move in certain directions based on whether the bones are fused or it's from laying in a certain position. Um, for synostosis, the definitive diagnosis can be made typically by a CAT scan. We use a low dose protocol that is good for looking at the skull, but not for looking at the brain. And that's because you can lower the radiation dose by focusing on the skull and not focusing on the brain as much. Typically for that, we may use it for more complex pictures if we're worried about syndromes or other sutures, or sometimes there may be an uncertain diagnosis. I can think of patients who have significant long, narrow heads, but maybe the other features don't fit for sagittal synostosis. And we want to make sure that they actually have it if we're going to treat it. In terms of workup, at least the way we do things here, we'll get into timing a little bit later, but obviously there are different timings for surgery and different procedures that can be done at different times. And especially in infants, there can be a time sensitivity. And our craniofacial clinic is not as frequent as our regular clinic. So infants, we may see just in a separate clinic to try to get people in faster because of the timing. Now, older children or second opinions or different things like that, we typically like to see in our multidisciplinary craniofacial clinic where there's multiple providers, including from neurosurgery, plastic surgery, genetics, so we can kind of have a discussion about the whole picture and best ways to move forward. I think one of the most important things and the most common referral we get is actually plagiocephaly, which is positional. And that's very important to separate from synostosis. I think the reason why we get so many referrals for it is because pediatricians don't want to miss synostosis. And so they get referred to us for to try to separate the two. And I think this is a good diagram that kind of highlights the difference in head shapes based on the different types of fusion. Um, for positional plagiocephaly, most commonly that's going to be confused with either coronal or lambdoid synostosis. And as we're going to get into it, lambdoid is fairly rare, so most commonly going to be coronal synostosis because metopic and sagittal are a very different head shape than the straightforward flattening. But the easiest thing and the way I tend to separate it is for deformational positional plagiocephaly, if you're laying on the back of your head, then that side is going to get flat as the head grows. Typically, the ear on that side is going to get pushed forward, as is the forehead on that side. So going back to high school geometry, you're going to get a parallelogram. And a parallelogram is very reassuring that it is positional. Compare that to coronal synostosis. The flat side is on the same side in the front and back. So we get a trapezoid. A trapezoid shape is something that worries us. And so that's something that we tend to think more about and would be more likely to think about imaging. Now, to get into the different types of synostosis, sagittal synostosis is the most common one that we see. It's about 40 to 60%. So about half of patients with a single suture that's fused have sagittal synostosis, and it's much more common in males. Here's a CT scan of a patient who presented with sagittal synostosis. And I think the top view is actually better for this, but you can see a long, narrow head. You can see what the sutures look like. Now, this child was a little bit older, so the metopic suture is closed normally, which we'll get into, but we can see the coronals and the lambdoids, but nothing where the sagittal is. As I alluded to, we do see a little triangle pointing forward, which also fits with sagittal synostosis. Metopic synostosis is, I think, the one that is sometimes the hardest to make a definitive diagnosis. Not that the suture is closed, but whether it's actually synostosis. And that's because the metopic suture is the only one of the major sutures that normally closes in the first year of life. The other ones, typically, you're fully grown before they close. And so a normal non-synostotic metopic suture can close as early as 3 months of age. Um, and metopic synostosis is about 10 to 15% of cases of single suture. But because it can close early, we still have all that head growth. And so there is going to be a period of head growth where it's not growing across the forehead. So that is something that there's the most variability, and we tend to talk about metopic synostosis we call trigonocephaly, where the forehead is a triangle, versus a rounded forehead that has a ridge. And I think there's most of a continuum for the metopic suture because of that early closure. And so here's an example of a CT scan in a patient with metopic synostosis that was born with a triangular head shape, and you can see it's more triangular. From the angle, we can see this large ridge there as well. You notice that metopic, you can see the ridge, but you don't really notice it as much from the side. It's more from looking down. Coronal synostosis is one, unlike sagittal, which has a female predominance. And because of where it is, it has more of a deformity of facial features. And unicoronal makes up about 20 to 30% of the non-syndromic cases. And here's an example of a CT scan in a patient with coronal synostosis, unicoronal, and we can see a lot of the different features on this scan. So looking from the top view, we can see here's the anterior fontanelle, which is open, but it is shifted. And you can see that the metopic suture is actually pushed off to the side because the side where the coronal suture is fused, the forehead isn't growing out, so it bulges more on that side. You tend to get the nose and the chin pointing away from the suture that's fused. And then you can kind of see from above how the orbit is flattened and coming back more so on the side that's fused, which again, you can appreciate more looking at if you look on the lateral view on the normal side, the skull looks normal, whereas you can see on the fused side where the eye is back. Bicoronal synostosis can occur in non-syndromic cases, but I think it's much more common in syndromic cases, and we'll often see both sides, the suture is fused, which causes a symmetric appearance, but the head is very towered, and oftentimes the fontanelle can be bigger because the head is trying to compensate. Lambdoid, you'll notice that I'm actually using a model because it's the most rare, so hardest to get consent to use images of actual patients. But what we can see is that there's a flattening in the back where the suture is, and on that side, the flattening, the ear is actually back. And so those are all the single suture we see. Obviously, there's a number of syndromes, and this list is not fully inclusive. But there's a number of syndromes that we see, as well as probably as we're getting a better sense of the human genome, more syndromes that are being diagnosed with more gene panels. And just along that line, in our craniofacial clinic, we do have a geneticist that's there that talks about even if you had genetic testing 5 years ago, we know so much more now that sometimes people will choose to repeat genetic testing because there may be new genes that have been discovered that may relate. For syndromic synostosis, we typically it's going to include multiple sutures that are fused, and sometimes they're not all at the same time. So I have patient examples of a patient that came to me as an infant with a unicoronal synostosis. We had a CT scan that definitively showed all the other sutures were open. We did a strip craniectomy for unicoronal, and that recovered well, but he then later fused the sagittal suture and has been diagnosed with a genetic mutation that is consistent with one of the syndromic synostoses. Oftentimes, to make the syndromic diagnosis, there can be other abnormalities. Sometimes the mid face is back. And then you can also, like in aperts, there's syndactyly where the fingers are together. So all of these findings can help make a diagnosis. And that's why we often see patients with our geneticists as well. In terms of treatment, there are obviously different options for things. The endoscopic strip craniectomy, and one misconception is we don't typically do the surgery through the endoscope. We use the endoscope to help with visualization. Now, with the strip craniectomy, you need something to help reshape the head. And you can do that with a helmet, or you can do it with springs. And I think different sites will have different preferences. We do both, but I think in younger kids tend to prefer the helmet. And the main difference is with the helmet, you have to go to appointments to have that helmet resized and fit. With the springs, you need to have another surgery to have the springs taken out. A little bit of an oversimplification, but those are kind of general differences. At older ages, we tend to go with the cranial vault reconstruction, which, obviously anteriorly tends to be a frontoorbital advancement versus a posterior vault. And then cranial distraction is often when you're trying to make more space. In terms of timing, we typically, for the endoscopic options, we looked at that growth chart before. We're relying on head growth to help reshape the head. We're not definitively creating the head shape with the endoscopic options like we are with the open vault surgeries. And so we typically like to do those by about 3 months so you can get more of that growth curve to correct the head shape. Now, obviously, there are exceptions, and we kind of think about those on a case-by-case basis, as there's a literature that patients between 3 to 6 months can get good results as well. But on average, there'll be less patients that get a good result at 6 months than at 3 months, and same thing as they get older. And there are theoretical differences. Maybe springs, maybe you could do a little bit later because there's a force being applied rather than just the passive remolding that the helmet does. And then for the open vault reconstructions, typically we're doing that at older than 6 months. I'm going to stop sharing for a second just to kind of show a few things. So this is obviously a model head that has sagittal synostosis. Everyone kind of has seen pictures of the helmets, but I did have an example of the kind of the springs. So effectively, this is what one of the springs looks like. And these get placed, you take the bone out, and then you can see where these little grooves are. There's these little feet that get placed underneath. And so the force of the spring effectively is, sorry, my hands are blocking, kind of pushing out against the skull to have it grow in that direction. The other thing are the distractors. And so these are, we can see there's two parts here with screws. And so what happens with the distraction is we're actually going to make cuts in the skull to separate it, but you leave it attached. And then the distractors get placed one on each side. And then you can turn this over time, and that makes these go wider apart. And so this allows you to get more head shape correction because you're separating it over time. Let me go back to the screen. And so the idea is if you do a frontal orbital advancement, you're bounded by the skin in terms of how much more space you can make. Whereas with the distractors, because you're going a slow amount each day, you can actually increase the head size more. So especially patients that you're worried about intracranial pressure, that's something that we can use and think about. And then, so we do a surgery, then obviously there's follow-up. Typically, follow-up, we tend to follow patients till at least about 6 to 8 years of age. And a lot of that is based on growth. And so a lot of the head growth will be done by that time. So we're less worried after that age. We follow the head shape for signs of pressure, things like headaches, especially waking up with a headache, to figure out if we need to do additional testing. We do recommend routine eye examinations because the optic nerve can be seen through a dilated eye exam. And if there is elevated pressure, sometimes we can see that on that, and that gives us a clue. We do tend to long-term follow the patients in our multidisciplinary craniofacial clinic, especially for patients who have syndromic synostosis, because they may have oral or airway issues or other things that are beneficial to think about and that we may have to do surgeries at older ages to help uh, repair and help those things. And I think that's where I'm going to stop. I think that kind of covers the biggest summary of what I wanted to talk about, and happy to take questions. All right, so I see one question here, and it says, "Are there any treatments available for 8-year-old with minor forehead asymmetry? Can it cause unilateral sensory neural hearing loss?" So obviously, I don't know all of the specifics. I would say it's unlikely that just having a forehead asymmetry would cause hearing loss. In terms of treatment for 8-year-old with minor forehead asymmetry, that's something more, especially in our multidisciplinary clinic, I tend to defer to my Dr. Yang, who's the plastic surgeon I work with, because there are things you can do on the outside of the skull if it's very bothersome, which is much less of an intervention um, than than a bigger surgery to reshape the whole head. Um, Question number 2, how does this diagnosis affect a child's ability to play sports, both contact and not non-contact? Um, I had the surgery performed at Pitt Children's in 1977 for SAT closures. I'm interested to see how the procedures have changed to help children. I was less than a year old. So I think in the short term, obviously, if we're doing this surgery in an infant, then they're not playing sports at that point. Long term, kids that with a single suture that we fix with say a strip craniectomy, I do not restrict sports, contact or non-contact. And With syndromic synostosis, I think the biggest thing we worry about are there bony defects or other things, and those are things we may fill in, but just having a diagnosis of synostosis in and of itself is not a reason to restrict. In terms of how the procedure has changed over time, I think some of the open vault remodelings are probably the same procedure that was done in 1977. But I think the newer things are the endoscopic, the assisted procedures with the strip craniectomies and the helmets or the springs. And the biggest thing, which I didn't really get into during the talk, is the length of stay, um, risk of blood transfusion, all of those things are much typically the endoscopic assisted surgeries, the patients leave the hospital the next day, sometimes longer, but on average the next day versus a longer hospital stay, and it's an easier procedure for them to tolerate. By what age can unilateral cranio be operated? Um, if no physical issues, does, quote, just aesthetic correct itself with time for mild left cranio? how long has the medical industry known about this condition? Um, so, I mean, for unilateral, I think some people, if you're doing an endoscopic, some people do it as early as 6 weeks. Some people may do it even earlier than that. I think on average, most of the time it's between 6 to 10 weeks of age for the strip craniectomy. Again, for open, often more, in the 6 to 12 months range. I think for unicoronal, especially, there are the aesthetic concerns with regard to the face, but it also can affect the eye. Um, and so that is something, in addition to the potential concerns about development or intracranial pressure, it can affect eye function as well. So I think unicoronal, especially, or the coronal is has aesthetic concerns, but there are less. And this has been known for, obviously we had a patient who was treated in 1977 ask a question, so it's been known for um, probably well before modern medicine. Um, then are there different treatment options for bilateral lambdoid? Um, Lambdoid, again, is very rare. Um, I think, like coronal, we will do bicoronal strips. You can do bilateral lambdoids. I personally haven't seen that, but you can also do an open posterior vault. So there are different treatment options. You can also do distraction. It just matters of age and what the exact findings are. Is there an age limit to how old CVR is still an option? Um, I think that's a little bit of a nuanced question in the sense that obviously you can do surgery at any age. Um, the likelihood of an impact or results being good. So doing a CVR in an adult, um, the benefits are going to be less than someone that's younger. We typically like to do it by about a year of age because the bones thicken, so it makes it harder to do the reconstruction. So typically, the results in terms of the cosmesis tend not to be as good the older you get. So really, in an older patient, you'd be doing a procedure more because of elevated intracranial pressure. Um, Although there are things you could repair um, with it at an older age. Um, how can another question, how can the scalp stretch enough to accommodate a CVR that overcompensates for extremely flat occiput? Um, I mean, I think that's one of the things where, as I was talking about before, sometimes you obviously our plastic surgeons do things for other conditions with tissue expanders um, or things like that. But that's sometimes why we'll do distraction, because you can get more of an expansion um, with it over time rather than the scalp being at risk with the scalp. Typically, if there hasn't been a lot of surgery, can get some stretch and you can undermine the tissue to stretch it more, but you can only go so far. um, and so that's why distraction is an option. um, Another question, do heads, quote, round out as kids grow older for those who have had endo procedure for lambdoid? Um, we do see that things will round out a little bit over time. I tend to think um, you get the most change and rounding out during that initial period with a lot of head growth. The rounding out really is really more based on the head growing. And so by a year of age, you're going to see a lot of what you're going to see. It can still continue a little bit, although sometimes we will see a little bit of regression. Um, when you've been in a helmet and you come out of the helmet, it can come back a little bit. So it may round out a little bit, but it's not clear to me that you're going to see a huge change, after a year or at 2 to 3 years of age. Another question: what's the likelihood to have another child with craniosynostosis, um, if you have a child with this? I've had a child with metopic craniosynostosis. So I don't know that I know the exact numbers. It's most craniosynostosis is what we consider isolated. But we know there is definitely a genetic component. And I recently treated a patient who parents were able to make a quick diagnosis in a second child with metopic because they had a first child who had metopic. Um, Clearly, there is a genetic component. We do not necessarily know that gene yet. And so that's something where I think why we have genetics in our craniofacial clinic and why there's new panels coming out all the time to test for those things. I think obviously if there's findings of things we know, then we know the risk is going to be even higher. Whereas if we don't find anything, I would think it's still going to be a little higher than the general population, but still not necessarily what we consider high. I hope that answers that question. Um, is a scaphocephalic head shape um, with a mild central ridge in the forehead region reason to refer to your clinic and a neonate 2-month-old, or maybe monitor for the central ridge to worsen versus improve and monitor the shape of the anterior fontanelle. So central ridge in the forehead probably relates more honestly to the metopic suture than the sagittal, which is more going to be the scaphocephalic head shape. I think it's one of those things that's hard to say without seeing it. I think in a 2-month-old, because of the timing of intervention with the lesser procedures we liking to do by about 3 months, we'd prefer to see kids like that and say they're okay and that we don't think it's synostosis or we want to watch it than have somebody watch it and come to us at 6 months, because then you just have the one option. So our preference, if there's a question, is to see patients early. Then at least that way we can kind of make that assessment of whether we think it is something we'd be concerned about or not. And it may be something that we see them and say, let's just monitor it. But we often like to be able to be the ones to make that assessment to kind of give you that best counseling. Another question: my daughter has bicoronal. We are seeing genetics. However, she does not present as, quote, syndromic. Our plastics stated knowing genetics would not make a significant difference in outcomes. Thoughts? So I think in terms of outcomes for treatment of a surgery. So in the immediate sense of if you have bicoronal synostosis, and whether it's genetic or not, the treatment of that in and of itself may not make as much of a difference. But I think, for instance, if there is a twist1 mutation or other genetic mutations, then there may be a difference in outcome based on the gene. But that's not necessarily something that, other than watching closely, the treatment would be any different. So in some ways, I would agree with the statement that it's not going to make a difference in outcome for that specific treatment, but I think it can make a difference in the long term. And I think the literature does support too that bicoronal probably has the highest rate of needing revision surgery. of many of the synostoses. Um, and I think too, we sometimes, so for instance, more recently, and different sites are different with Apert syndrome, for instance, um, we've shifted our protocol, and I mean protocol, it's not always, but we've been doing a lot more early bicoronal strip craniectomy as the treatment in APERTs and following versus some sites that wait and do an FOA later or a distraction later. So there's a lot of different ways to do it. But that's just something, if knowing you have a syndrome, sometimes it may influence how we think about it. Another question, will my child look different immediately after surgery for craniosynostosis? The answer in all cases for that is yes. The difference is the extent to which that is. So obviously with an open vault, um, um, with an open vault surgery, you're going to have more of a correction immediately, and you're going to have more swelling. But in the sense of open vault, you tend to overcorrect, and then you'll see it kind of regress some over time, hopefully to where you want it to be over time. With the strip craniectomies, there tends to be a change, but it tends to be a little bit more mild, and we see more of the change over time. Um, is there a particular reason providers do not want to give their opinion on which type of surgery to do, endo versus CVR? It is difficult as a parent to make this decision. It would be nice to get more guidance if age allows. I think sometimes, their synostosis is something that at the meetings is treatments somewhat what I would say some ways controversial. Not controversial in the sense of what's right or wrong, but what's best. And we have at our meetings, people will get up there and argue back and forth about strip craniectomy versus open CVRs, and is one better than the other? Um, and so I think there may be providers who believe there is what we call equipoise, meaning there isn't a right or wrong answer. Um, and for that reason, they don't want to give an opinion. I think in my practice, I think generally if somebody is a candidate for the endoscopic, that's the way I tend to lean. But I think there's risks and benefits of each. And I think there may be reasons why in a certain circumstance, one patient may be better for one and one patient may be better for other. And I think that's a little bit of a case by case basis. Um, Another question, can synostosis be suspected prenatally? Yes. Um, the it's just one of those things where sometimes they can see if the head shape is grossly different, then they can suspect that. But we will sometimes see it, but it's not a common prenatal referral that we get. I think I've seen a few patients that it was suspected and then they were born and had it, but it can be seen. What is the ideal cephalic index for sagittal patients? My son started out after his endoscopic surgery with an index of 80. He has been in a helmet for a month and he is now at 85. Typically, I've always thought of 75 to 85 as kind of quote normal. Um, Below 75, especially below 70, is scaphocephalic. Above 90, you start getting into brachycephalic. Um, I think after helmet, 85 is great, because, like we said, sometimes it will regress a little bit after you come out of the helmet. So being at a high range of normal is a good thing. Um, Another question, is it possible that untreated unicoronal metopic synostosis caused hearing vision loss on the same side? The child is 9. Um, so I mean, unicoronal and metopic are different sutures. It's hard for me to kind of comment on that. without knowing more. We don't typically suspect of synostosis as causing um, hearing loss. Obviously, there can be other things going on. Vision loss, there are effects on the eye, but of unicoronal, but you would expect to see something on an exam that would fit for that. Next question, are there different delays associated with different types of non-syndromic synostosis? So yeah, like as I had mentioned, we can see on cognitive testing, so like Bailey's testing and other things, that patients with um, non-syndromic synostosis can perform worse on those tests. I think especially more so in metopic and unicoronal. But it definitely is a case by case basis, as there are patients who don't have those. And that's one of the things that I think we're kind of definitely needs more study to look into further. Um, are there ways to confirm synostosis that don't involve radiation? Um, and so, like I said, the most I think especially things like sagittal and unicoronal, um, we often feel pretty comfortable making that diagnosis with clinical examination. I think the CT scan is the most definitive way. Um, we've attempted looking with MRI scan, which is non-radiation, but doesn't really show it as well. The lower dose protocols, I think, have much less radiation. I think in Europe they'll do ultrasound, which I don't have much experience with that as that being a definitive diagnosis. Um, but yeah, so that's you can, but the definitive diagnosis typically I would say is CT. Um, our son has bilateral lambdoid. He's 7 months old, scheduled to have CVR at 8 months. He is doing well developmentally. However, are you aware if it makes a difference to do the surgery at 8 months versus earlier? If this is late, do you have suggestion on what to do after the surgery? So I think I had alluded to that a little bit in the talk earlier, that um, it's a little bit of a chicken and egg question, and we don't know 100% whether the delays associated with synostosis are that they have the same underlying um, cause. So is there a gene that's not acting properly? And in that way, treating the synostosis um, doesn't affect delays at all? Um, or is it that the brain growth is restricted, and therefore treating it helps? We don't know that answer, so it's hard to answer that question. I think theoretically, if it's brain growth restriction, then treating it earlier should help. Again, there aren't studies that when they looked at ages, the age groups were too big. So we didn't really see much in the way that says it. So we can't really say that it is a definitively anything. And I think so. There's not really suggestions on what to do after the surgery either. I think just if they're doing well, I think just be supportive in terms of kind of schooling, and if there's questions, then infants and toddlers, or having assessments to see if there are things that can help. Um, what are some questions a parent should ask the surgeon at the initial appointment? Um, I mean, I think it's one of those things. I think the questions about the diagnosis, are you sure about it? And then what are the treatment options? We all do things a little bit differently, and I think clarifying with the surgeon what they tend to do and why. Um, and I think just so you can have an understanding of their logic, of why they approach it, and then um, are there reasons why it may be different or different suggestions in your child versus anybody else? Um, any reason why a provider would not suggest endo and jump straight to CVR? So, I mean, I think there's a couple reasons for that. One, there may be a reason why endoscopic may not be a good approach in that specific child, or there may be a surgeon preference. There are surgeons out there who believe that open CVR is a better surgery than endoscopic. Um, and so um, that may be their preference. I think there are also differences if you're seeing a plastic surgeon or a neurosurgeon. Um, Neurosurgeons are more likely to be the ones who do the endoscopic versus plastic surgeons tend to be more involved in CVR. Now, there are obviously going to be institutional differences in that, but I think those are things. So you can, I mean, that's a question you can ask. 20, another question, will my child's hair grow back where the incision is made? Sometimes. Everybody's a little bit different. I think oftentimes directly on the incision line, no. Um, but it's often easy to cover. Sometimes infants, the incision will stretch a little bit. So that's something that years later, sometimes the plastic surgeons may revise the big incisions if it's bothersome to people. But so I would say for the most part, it's not noticeable, but you may not have a lot of hair growth back. And then the last question, besides neuroplastics, genetics, helmet clinic, are there other specialties that you recommend should be involved with a bicoronal diagnosis? So ophthalmology, we usually have, like you talked about, we all have all our patients with eye exam. Often bicoronal can be have facial issues. So, the plastic surgeon I work with is also a dentist. And then we have an orthodontist as well that'll see some of the older patients. Um, I think there can be uh, things with neuropsych testing, ENT, depending on sometimes with our patients who have mid-face abnormalities, ENT is involved. Sometimes they're getting sleep studies. So I think a lot of it really depends on the exact condition. But I think the main addition to the list would be ophthalmology um, for making sure that there's no concerns with the eyes. And I think we will end there. Again, I think there's an email if there's other questions. And then I've been asked also if to please submit feedback. And obviously, if there are things that weren't clear or other things that might have been helpful to include, then definitely let us know. Thank you.